same time, he also has his independent research program as assistant professor in Chinese Institutes for Medical Research. So his work actually really cover a broad spectrum of neurological disorders, and he studied the specific features of initiation, progression of inflammatory and immune responses of central nervous system, as well as cerebralic modulation of neural inflammation in patients with MS and stroke. Also corresponding to studying the animal models. His work contributes to discovering the role of bone marrow in deriving a neural inflammation in chronic brain injury, as represented by patients with multiple sclerosis, as well as acute brain injury, such as stroke. I think his research program and research lab dedicate to explore new strategies for treating neurological disorders through targeting bone marrow hematopoiesis system. I think Kaping really accomplished quite a lot, both academically and also clinically, with different different accomplishment. He was received numerous awards. I just list a few. He got in Beijing Talent Awards and also Young Talent Award, Chinese Stroke Association. I think 2024 he got Young Scholar Awards from Chinese Society for Immunology. So I think probably Kevin going to tell us today about his recent work related both clinical and research side for myelopoiesis in neurological diseases. So thank you so much, Kaibing, being with us today, and then we are very much looking forward to your talk.
Thank you, Dr. Wu. Very thanks for this invitation and the kind of introduction. And my group and I really benefit a lot from listening to this wonderful series. So today I will introduce some work from our group in recent years. So the basic logic in our group, what we're doing is to study the interaction between the central nervous system and our peripheral immune system. As we know, any organs of our immune system and any tissue are actually highly innervated by nerves derived from our central nervous system. So any injury or any change of the microenvironment in the brain can be quickly related to our peripheral immune system, these systems can quickly respond to the injuries that happened in the brain or the spinal cord. And at a response, these motivated immune cells can then home into our brain, and these cells can then further be modified in the specific microenvironment of the brain provided by focal cells. And today, the work in our group in the last years actually we focusing on the bone marrow hematopoiesis system. As we know, the bone marrow is the only hematopoiesis tissue in adult subjects, and it sustains the renewal of all our immune cells in the peripheral blood, and it provides the resources of all cells in the immune system. And the work from recent years has just broadened the role of bone marrow in our health and disease conditions, as it's not just play as an arsenal to just provide these weapons for our immune system to combat the infections and the diseases, but it's also actively participating in many conditions like including infections and acute injuries in myocardium and also stroke and acute brain injury. And it's also a very important part to keep our immune memory to protect the memory cells in our system. So today, our work actually focusing on the cells that are located in the bone marrow, that how HSCs give rise to myeloid cells and the lymphoid cells. And from the clinical perspective, we are interested to know how this system reacts to neurological diseases, including chronic inflammatory disease like multiple sclerosis, as well as acute brain injury. So the first part of my presentation today will look at the impact of bone marrow responses to MS and chronic neuroinflammatory diseases that mainly causing the young people disability worldwide. And because it's an autoimmune feature, it's continuous relapse and remitting with chronic progression of neurological deficits. This MRI slide shows the characteristic the typical lesions in the patient of MS, which showing the demyelination plaques that's located close to the ventricles, and also chronic brain atrophy that's indicating these patients develop the neurodegeneration. The pathology of MS for the past three decades, a great breakthrough is the identification of myelin reactive T cells that be activated in the peripheral blood and their migration to the central nervous system and causing demyelination and causing neuroinflammation and demyelination and axon injury. And if we look at the distribution of lesions in MS patients, it can broadly impact the whole CNS system, including optic nerve, cerebral cortex, brainstem, and the spinal cord. So the appreciation of the role of myelin reactive T cells in the pathogenesis of MS has have boosted the development of disease-modifying therapies in the past 2 decades. And if we look at this treatment, this mainly targeting the peripheral immune cells, mainly T cells and B cells, either blocking their motivation or blocking them or inhibition of their migration or infiltration to the CNS, or we can just deplete B cells in the peripheral. We notice that these all drugs mainly target the peripheral T cells and B cells. And with the helping of these high efficacy treatments in the past 2 decades, we now can well control the relapses of these patients. However, when this risk now can be well controlled for these patients, previously ignored or very subtle aspects of the disease has become more obvious. Is we call it period. What I mean is disease progression independent of relapses. That means even there is no relapses for in this patient during this period. For example, there is no relapses, but the neurological deficit still declines in these patients. And for all this current treatment, the period responds poorly to current therapies. So based on these observations, we previously proposed that the disease course of MS patients may be driven by 2 forces. The first one is what we have highly appreciated is the peripheral immune response that mediated by T cells and B cells, which causing relapses in these patients. And another force is chronic and continuous intrinsic neurodegeneration, which can occur very early in the disease stage. But the mechanisms are still not very clearly investigated, and the current therapies are ineffective for disease progression in these patients. And if we roughly MS patients, we can roughly classify them into 2 types of lesions. The first one is active lesion, which mainly caused by activated T cells and B cells and migration to the brain, and which are targeted by the current therapies and can be well controlled. However, the other one is chronic lesion that causing neurodegeneration and the disease progression. And the myeloid cells play a major role as suggested by the pathologic studies. But currently, we have no highly effective therapies to combat such compartmentalized neuroinflammation to slow down the disease progression, progression of the disease. And the other part I want to introduce before showing our own data is the HSC transplantation. As the appreciation of autoimmune T cells in the pathogenesis of MS patients, there has been a decade trying to using hematopoietic stem cell transplantation to restore the peripheral immune system to treat these patients, especially for those refractory patients that respond very poorly to current therapies. Even though these are conducted in very small scale clinical trials, but several trials collectively has suggested that hematopoietic stem cell transplantation can be higher effective in limiting the disease activity, and more interestingly, it slow down the disease progression as referred by the increase of the disease score, and even it can showing a little bit trend in improvement of the neurological deficit. However, even we have this clinical evidence, but till now we don't know how the bone marrow features of MS patients are showing, and whether or how these bone marrow immune responses contribute to the disease progression or neuroinflammation. And to answering this question, the first work from our group is to we collected the bone marrow samples from our MS patients and using single cell RNA-seq to characterize the bone marrow immune landscape in our MS patients. We surprisingly find out that in our MS patients, the hematopoietic stem cells are largely expanded in the bone marrow of MS patients, and together with myeloid cells, including monocytes and neutrophils, are increased in the bone marrow of MS patients. This suggests that there might happen aberrant myelopoiesis in the bone marrow of our MS patients. And this phenomenon was then confirmed in our mouse model and EAE model and MS model, and we further using transgenic hematopoietic stem cell non-tracing mice to in which we can induce T-tomato expression in newly generated HSCs by tamoxifen treatment, and after which the downstream cells that rise from these HSCs will all be labeled by T-tomato. And we can clearly find out that in the bone marrow of these transgenic mice after EAE induction, we can identify newly generated neutrophils and monocytes are increased, and these cells can readily migrate and infiltration to the CNS and causing neuroinflammation. And then we are interested to what is the driver of such bone marrow responses in MS or EAE mice. As we know, a major driving force of MS or MOG 35-55 EAE mouse is autoreact T cells. We then want to answer whether these autoimmune T cells are homing or or concentrate or accumulated in the bone marrow in mice, and we applied a tetramer to detect such autoreactive T cells. When we surprisingly find out that the proportion of many reactive T cells in the bone marrow is even higher than lymph node and peripheral blood, which has previously been recognized as a main space where these autoreactive T cells being generated and play roles. And then we're using a transgenic mice model, 22 mice, which T cells can react can be reactive to MOG 35 to 55 by can automatically react to MOG 35 to 55. And we isolated the CD4 T cells from this mice, and after peripheral activation and then transfer to RAC2 knockout mice. And we show that transfer of these T cells, only T cells can readily boost the bone marrow myelopoiesis with increased the myeloid progenitor cells and as well as neutrophils and monocytes. This suggests that 22 T cells or these many reactive T cells can really activate the bone marrow response we observed in our mice. And then we want to delineate how these T cells boost bone marrow myelopoiesis. We sorted out 22 T cells from 22 mice and performed an ELISA array, and we found out in these T cells, we surprisingly found out that CCL5 is the most highly expressed cytokine in these T cells, and which was also then performed by flow cytometry. And then whether CCL5 is the main driving of HSC myelopoiesis, we then analyzed whether CCR5 are expressed in our in the HSCs of 22 mice. We performed an RNA-seq of the HSCs isolated from 22 mice, and we can find out that CCR5 actually are highly regulated in the hematopoietic stem cells of our 22 mice, which was also then confirmed by flow cytometry. But how CCR5 are being involved in such a myelopoiesis system? We then go back to the literature, and we find out that actually the expression of CCR5 is kind of aging features of our hematopoietic stem cells, and which contributed to minus skewing of hematopoietic stem cells, giving rise to increase the minus cell generation observed in aged mice. And with this appreciation, as we kind of collected that what we observed in our MS patients' bone marrow, which is partially like the myelopoiesis that's being observed in aged subjects. And the increased CCR5 and 2 CCR5 thing was also confirmed in our MS patient bone marrow. So then we using a chimeric mice to generate CCR5 knockout HSCs in these mice, and we demonstrate that if we knock out the CCR5 in bone marrow, it can reduce or inhibit the generation of myeloid progenitor cells, as well as the output of mature myeloid cells, including neutrophils and monocytes. And also, this might show the improved neurological deficit and the inflammation of the spinal cord and ameliorated demyelination. So, in a brief summary, in this work, we identified that these mining reactive T cells can home into our bone marrow, which gave rise to which activated our HSCs to minor cell minus cell generation via CCR5 to CCR5, and demonstrate that the CCR5 might be a potential therapeutic target in MS. And following this work, collaborated with Professor Liu Hong from Shanghai Pharmaceutical Institute, we developed a novel CCR5 inhibitor, we named it Cyroveroc, and we tested its efficacy in preclinical animal models, and this drug has now been approved by Chinese FDA for clinical trials. And a phase 2 trial, we named it MS, means Cyroveroc for treatment of MS, has been planned. This is the first part. We demonstrate that the bone marrow myelopoiesis system actually drives the neuroinflammation and disease progression of MS patients. And the other part I want to share today is the contribution of bone marrow myelopoiesis system to acute brain injury. As we know, after acute stroke or trauma, a big and acute injury of the brain tissue occurred, which can subsequently activate a cascade of neuroimmune responses and are closely associated with the disease outcome of this injury. And this is a brief introduction of acute brain injury, including the ischemic stroke and hemorrhagic stroke and trauma. Are all with higher incidence burden in China. So the first work we in patients with intracerebral hemorrhage with bigger hematoma, we can collect in these patients who received the surgical treatment, we can collect their scar flaps and flush out some bone marrow samples. And with these samples, we characterize that actually at the very acute phase of disease, as early as 1 day, just within 1 day of the occurrence of the acute injury, we clearly identify that the hematopoietic stem cells are increased in the bone marrow of these patients, and very interesting, we also identified that the myeloid progenitors are also increased in the bone marrow of patients with intracerebral hemorrhage. But the progenitors of lymphocyte progenitors are inhibited or decreased. And these observations were also then confirmed in our mouse model induced by intracerebral hemorrhage. We identify the hematopoietic progenitor cells and the long-term hematopoietic stem cells are increased during the acute phase of ICH, and with increased proliferation activity as always, we're using a PET CT to identify that the spine bone marrow activity are increased after intracerebral hemorrhage in this mouse. And also, similarly, using this transgenic mouse model, we not only traced the increased HSCs, and we shown that this increased HSCs actually giving rise to mainly a subtype of monocyte. We name it L160 no monocyte, or in patients it's we name it petroleum monocyte or alternatively activated monocytes. This kind of monocyte, as we know, or if you are familiar with monocyte, we know that this kind of monocytes are mainly contributed to the clearance of tissue debris and also modulation of focal microenvironment. And we find out that this subset of monocyte actually are highly express IL-10, which we know has the immunomodulatory features. And a brief summary of this work, we identify that the acute brain injury caused by intracerebral hemorrhage can activate our bone marrow hematopoietic system via sympathetic nervous system and contributing to the generation of our IL-10 positive monocyte, and this monocyte can modulate the acute neuroinflammation in the surrounding in the perihematoma area and improve the clinical outcome of such acute brain injury. And in the following work, I will not introduce more. Is we identified that such features are impaired in aged patients, which are partially associated with the poor clinical outcome of aged patients with acute brain injury. So the next part is that in the clinical setting, when we management of a patient with acute brain injury, especially for the inpatients in our ward, and a large proportion of this patient will develop stroke-associated complications like infection, and major our efforts actually are contributed to the management of these complications in our stroke patients, especially the stroke-associated pneumonia that I will pay much attention to in my following presentation. Stroke-associated pneumonia occurs in nearly 10% of stroke patients, which become even higher in severely injured patients and also in patients that within the intensive care unit. And we, as a physician, we are very concerned. Well, very concerned about the stroke-associated pneumonia because it's can definitely increase the mortality of this patient during the acute phase, as well as worsen the neurological symptoms of these patients. However, in the two large clinical trials that published 10 years ago, using a prophylactic antibiotic is the most powerful tools that we can human can use to combat infections. However, both these two trials failed to show that these antibiotics can prevent the occurrence of stroke-associated pneumonia or improving the outcomes of this. And this is a comment in the journal by the after the two trials are published, and they propose that the results of these two trials suggest that the stroke-associated pneumonia might be partially a pneumonitis and with more non-infective inflammatory components may contribute to the occurrence of stroke-associated pneumonia. But what is it? In the past 2 decades, joint forces from our group and as well as other groups in the world, we characterized the immune response post acute brain injury, and I want to stress that just after the very acute phase, during the subacute phase, maybe 24 hours or even earlier, and our brain injury can shut down our peripheral immune system to an immunodeficiency status, as shown by the atrophy of lymphoid organs, as well as the lymphopenia and the dysfunction of our lymphocytes. And we kind of collected that such lymphopenia or immunosuppression status may contribute to increased infections risk of these patients. And phase 2 trial from our group to demonstrate that using a beta blocker to block the neurogenic signals to our immune system to protect our lymphocytes to prevent the infections is now still ongoing. However, besides this, if we further go back to the occurrence of stroke-associated pneumonia, it mainly takes place in within days 2 and 7. However, the neutropenia or the immunosuppression, as I just mentioned in previous slides, which is become very obvious during day 3. So what happened before the occurrence of stroke-associated pneumonia and before the occurrence of lymphopenia or immunosuppression? What happened at the very acute phase now, which haven't been tested in previous studies? To answer this question, we previously using we collected patients with acute ischemic stroke, but during a very acute phase with no any symptoms of pneumonia or fever or upregulation of peripheral white blood cells. But some of these patients may need to do a broncho to need to machine supported breath, and we have a chance to collect the broncho alveolar the white fluid of these patients. Using single cell RNA-seq, we showing that compared to controls in our stroke patients, in the control subjects, there's a large amount of alveolar macrophages in the BARF. However, in our stroke patients, this changed to neutrophils. There's a great number of neutrophils accumulated in the BARF of our stroke patients. When we compared the phenotypes of our neutrophils in stroke patients compared to its paired peripheral blood, we're showing that these neutrophils that accumulated in our lung actually are highly pro-inflammatory and permeability with upregulated I1 beta and VEGF-A. And then this observation was further confirmed by flow cytometry of BARF collected from stroke patients, which showing that neutrophils are the #1 cells that accumulated during the very acute phase of stroke, but during which the patient are still absent of symptoms of pneumonia. And a more interesting part of this data is that we identify that in the neutrophils that accumulating in the BARF of our stroke patients, over 1/3 of these neutrophils are immature neutrophils, suggesting that these neutrophils are just be generated from progenitor cells. And then we go to mouse model induced by middle cerebral artery occlusion. And we also show that in the lung tissue of these mice after MCLO induction, the neutrophils in this lung are obviously increased other than compared to other cells. And also the immature neutrophils proportion are also increased in the lung tissue of our mouse. And then we want to know whether these neutrophils causing the acute lung injury and subsequent pneumonia occurrence in our mouse model. And we depleted these neutrophils before model induction and by an antibody targeting I16G. And we're showing that in mouse that's be depleted with neutrophils, the acute lung injury during 1 day and the subsequent pneumonia at day 3 are also improved in these mice. This suggests that these neutrophils does contribute to acute lung injury and the subsequent pneumonia. And then a more interesting question that we are interested is that where is this neutrophils come from? As we know, the lifespan of neutrophils are very short, and we identified that over 1/3 of neutrophils in the BARF or in our stroke model in the lung of our mouse are immature neutrophils. Then we propose that whether the myelopoiesis happening in the non contributed to these immature neutrophils. To answer this, we first detected whether these projected cells can be detected in the non-tissue of our mouse, and we collected the non-tissue of MCL mice, and we clearly detect that a population of non-term hematopoietic stem cells, as well as myeloid projected cells, are increased in the non-tissue of MCL mice. This suggests that this HSA might contribute in situ minus neutrophil generation. But whether uh, uh, these hematopoietic stem cells or projected cells can functionally generate neutrophils in the non-tissue way. To answer this, we isolated the CKD positive cells from our non-tissue of MCL mice and seeded these cells to an OP9-DR1 cells that can support hematopoiesis in vitro. And after 7 days, we clearly identify that CK cells isolated from our MCO mice can form a clearly hematopoietic cluster, demonstrate that these cells can generate blood cells in vitro, and these cells are functionally hematopoietic stem cells or projected cells. And then also the flow cytometry showing that the neutrophils are increased in these cells. And then we are interested in how these HSCs moving to the lung after stroke. Or stroke lung itself has HSCs, or these HSCs actually migrate from bone marrow or other places to the lung after stroke. To answer this, we performed a parabiosis of wild-type mice and T-tomato mice. And after 2 weeks, we induced brain injury in these wild-type mice. And after 1 day, we detect whether the T-tomato positive cells can migrate to the lung of these mice. Now we clearly showing that after 1 day, 1 day just after the MCO induction, we detect that the T-tomato positive HSCs are increased in the increased in the non-tissue of these white mice, which suggest that the T-tomato positive HSCs might migrate from the bone marrow of T-tomato mice to the non-tissue of these white pairs. And also we detect that the myeloprojectors are also increased. T-tomato myeloprojected cells are also increased in the wild type lung after MCO. And very interestingly, these motivated T-tomato positive cells are selected are selectively accumulated in the lung, as shown in this slide. But when we look at the bone marrow, these cells are nearly detected in the bone marrow of these cells of the white mice, suggesting that these HSCs are highly selectively mobilized to the lung, but not other tissue, even not bone marrow. So what is the molecules that are tracking this HSC from bone marrow to the lung? We first screened that the conventional cytokines that has been known are involved in the retention or migration of hematopoietic stem cells, and we showing that the conventional something like CXL12 kits ligand are highly activated or highly upregulated in the bone marrow. However, the CCL2 which we all know is we all know is a major chemical that recruit monocytes, which are highly activated upregulated in the non-tissue of our MCL mice, but not in bone marrow. And we showing that we are interested to find out that in the HSCs we isolated from our lung, and this HSC, nearly all HSC in the lung express the CCR2. That suggests that CCL2 to CCR2 axis may contribute to the migration of hematopoietic stem cells from bone marrow to the lung. And to demonstrate this, we then generated CCR2 non-colonized with a CD45.2 CCR2 non-colonized with CD40.1 white mice. And we're showing that these CCR2 knockout hematopoiesis cells are failed to migrate to the lung. This suggests that CCR2 is responsible to the migration of bone marrow hematopoietic stem cells to the lung. And also, pharmaceutical blocking of CCR2 can inhibit the increase of hematopoietic stem cell numbers in our lung, and as well as downstream myeloid proliferative cells, as well as neutrophil counts in the lung, and also ameliorated the acute lung injury and the subsequent pneumonia. So, as we know that the differentiation of hematopoietic stem cells to either neutrophils or monocyte or lymphocyte are actually driven by different transcription factors. So we are then keen to know what transcription factor that drives those non-HSCs differentiated to neutrophils in the lung. To answer this, we sought the LSK cells, mainly in the hematopoietic stem cells and the progenitor cells. And we performed bulk RNA-seq to show that genes that associated with myeloid cell differentiation are highly upregulated in the non-LSKs compared to sham control. And the analysis of transcription factors that may driving such myeloid cell proliferation, we focusing on 3 transcription factors that are highly suggestive of myeloid cell generation. And then we tested these 3 transcription factors by using siRNA to knock down the in vitro. The test of these three transcription factors, we only show that the knockdown the transcription cream actually inhibited the formation of hematopoietic clusters, which suggests that cream might contribute to the differentiation of neutrophils of non-HSCs, and more importantly, the differentiation of lymphocytes are not impacted by cream, which suggests that the cream as a key driver of generation of neutrophils in the by the non-HSCs. So in a brief summary, that in this part of study, we provide actually a novel mechanism frame to understanding the occurrence of stroke associated pneumonia. That means during the very acute phase, the accumulated neutrophils or the in situ generation neutrophils contribute to an acute inflammatory injury, which then impaired the alveolar structures and increase the susceptibility of lungs to infections, which contribute to the occurrence of stroke-associated pneumonia. By blocking such pathways can inhibit the generation of neutrophils and ameliorate the non-inflammation and prevent the occurrence of stroke-associated pneumonia. So in a brief summary, so in the past years, the work from our group mainly contributed to the discovery of bone marrow myelopoiesis system, contributed to the generation of neuroinflammation in acute brain injury, as well as its response to acute brain injury, as well as its contribution to the peripheral complications of stroke. And the understanding of such mechanisms can provide us opportunities to treat such diseases. And some of our some of our discoveries, like this R5 inhibitors, now has been in the clinical trials. So I would thank my colleagues from Beijing Tiantan Hospital as well as Cymer and the Tianjin Medical University in helping this this project, as well as our collaborators from Vanderbilt Study and Nantung University, as well as 304 Hospital, and the fundings that support our work. Thank you very much, and I would like to take any questions.
Hello, Kevin. Yeah, this is a wonderful talk. So many so comprehensive knowledge about information and hematopoiesis. If you For the audience, if you have any questions, please leave your question in the chat box, or you can just direct ask your question yourself. I'm gonna kick off the several
Recording
questions.
stopped.
I feel like this is very exciting. So I'm gonna ask a question from your last part first, and then going back to the your maybe first part. So interestingly, can you share your comments why this stem cell movement is lung specific? Because it can also can it also be happen to other tissues? Just quickly want to get some of your feedback. Although you show the factor CREM, right? But I think it can be also affected by the microenvironment. Is that right?
Yes, yes, that's a great question. So, currently, actually, we don't know why this HS is selectively moving to the lung after stroke. But some evidences suggest that those HSCs moving to the lung are actually CCR2 positive. And we also identify that even there's a small part of HSCs in the bone marrow, actually, the CSR2 positive HSCs are actually expanding in the bone marrow of stroke mice. And we think that it was this specific subtype HSCs are actually motivated from bone marrow and migrate to the lung, and which contributed to the selectivity. And
But do
but
you, but do you see can you like, I know you're doing flow, but can you like do the sectioning and locate where it is? Because, I mean, I think, it can also move to peritoneum, right? Or like any other organs to cause inflammation.
oh
Why it
yeah,
is a
yeah,
lung specific? This is a question I'm curious. Because it may be like just stay into a specific area in the lung where it can really, proliferate and differentiate, right? Otherwise, why it is a lung specific?
okay. Yeah, so we are still working on this kind of ongoing work, and we actually we have some preliminary data to showing that these HICs are located in the interstitial in the peri alveolar area of this lung, and how lung became a pro hematopoiesis organ, and what cells in the lung contributed to the formation of a hematopoietic niche is still an open question. So I still have no answer for that.
I see. So you kind of link the CCR2, CCO2 as a mechanism to for the inflammation, right? I'm just
Mm.
curious, like CCR2 affects a lot, right? Not just only myeloid,
Yes,
but also
yes, big question. Yeah.
lymphocytes. And then for
Mm.
the myeloid, it also affects the monocyte, migration. So how can you exclude the possibility that your overall immune suppression is driven by monocyte infiltration?
So in this project, we actually we cannot exclude that CCR2
Right.
blocking
Hmm.
the effects on monocyte. We just showing that CCR2 are actually involved in
Oh,
this subset
yeah.
of neutrophil migration. And
Yeah.
on the other part, I think from a treatment perspective, the
Hmm.
impact of CCR2 might not only blocking such neutrophil response, but also the pro-inflammatory monocyte response might also be beneficial from a clinical perspective to the acute non-immune responses.
Yeah, in other words, you should consider to deplete CCR to insert stem cells specifically, right? So that you can really sure that, that's a stem cell going to the lung and then differentiate proliferate, not like, differentiate somewhere and then become monocyte and then, go into the lung. This is a question that I have in mind. Is that any possibility like that?
Oh, well, I think it's possible. And currently we cannot exclude this. Uh, but what we can show is that we does observe that this HA is generated in situ neutrophils, neutrophils in the lung.
Okay. I want to ask another question, and I let the people to ask because I this is so just interesting to me. So back to your the another story about ICH, right? In that
Yeah,
case, is that do you know? Because that's not related to the stem cell migration, right? That's that. I'm just curious about the Q in ICH to drive myelopoiesis. What is the Q, and why the Q actually differentiate monocyte to become like C low? And then, there's
yeah.
also other like hemorrhage models, like for example, like you must know Moyamoya disease, right? Or like intracranial atherosclerosis. They all can have the leaky the
Mhm,
blood leak in the brain, right? Will those models, I mean other models that has the hemorrhage will
mm.
have produced the same cue that drive
Yeah,
specifically
exactly.
monocyte and like C low monocyte.
Yeah.
Comment about it?
Yeah, that's a great question. And um, actually, from my perspective, I think the driving of bone marrow responses after acute brain injury is mm, kind of stress uh, response, and also in our work, we showing that it was increased sympathetic nervous system input that contributing to such bone marrow responses. And in our SH model, and we mainly show that actually we observed it in a little bit uh, later stage of the disease, and then we showing that the most boosted or most highly generated cells is LY6A no. But
Mm,
in that project, we showing that it was the increased input of sympathetic nervous system that actually contributed to this re, uh,
mm,
to this res, to this response. And in data that I haven't shown is that I identified that is the beta receptor actually contributed to this. And what is the mechanism that selectively drives the differentiation of LY6A no monocyte?
mm.
Well, for the intracellular molecular machineries, we still don't have clue, and we haven't solved out this problem. I think.
I
Uh,
see.
in
The
this
reason why
specific.
I'm asking is that, for the because I'm not in this field, but
Mhm,
based on what I learned and know is that, during the myocardial infarction, maybe
mhm.
ischemia,
Yeah, they are very
injury,
similar.
usually.
They are very similar observations.
Yeah, but usually
Yeah.
people show that in the first, for example, 3 days,
Mm,
right? It
mm,
has to
yeah.
it has to be like more like C high, because you want
Mhm,
monocyte going there and then during the inflammation. And once
mhm,
when monocyte going in, and it will differentiate to become macrophage and then to become M2 to like fix, right,
mhm.
the injury. So you want like C high to be there first and then become like C low. But then what
Yeah,
you show is that
exactly.
it's
The
like
high
C
is
low
first.
specific.
Yeah.
Yeah, but in
Yeah,
your
yeah.
model, it's all like C low, right? Like then there will be no
The
monocyte going to the
during the very acute phase is still LY60 high. In, we can trace
I
in
see. I see.
that the LY60 high monocyte are first reactive and generated, and then after mass the generation and also the activation or
I see.
motivation and infiltration of LY60 high monocytes are declined, and on the contrary, the LY60 low monocyte increased. It's a different phase.
I see, I see. So yeah, so the Q might, coordinate and modulate different phases, and then later on, in the end, it's like low secreting IL-10. That's what you're proposing, right?
Yeah. Mm.
Got it. Okay, I'm gonna let people ask because I mean people ask quite a few questions in the chat box. So Yang Qianlin he asks like great work for your first story. Myeloid cells infiltration also increasing other organs and contribute to disease progression.
Sorry, let me check out.
Chat box, yeah. The
Okay.
first story, I think, is a CCR5 story.
Mm-hmm.
It's a myeloid cell infiltration also increased
Concentration also
in
increasing
other
all the
organs.
organs with this approach. Um, Well, in this work, we didn't look at other organs in the EAE mouse model because the main injury in this model is happening in the brain and the spinal cord. So we observed that these highly motivated neutrophils and monocytes mainly infiltrated to the spinal cord. But whether its impact on other organs contributed to the disease progression, well, I cannot exclude this possibility. But in the setting of EAE or MS, I think the central nervous system is the major or the first organ that be targeted.
Okay, he has another follow-up question. Maybe I'll let him to finish the question. So he continue asked that is there any reports show that cancer patients have bias and myelopoiesis?
Yeah, that's a very good question. I think it's a very recent work just published in Nature last year and showing that in non-cancer patients, actually they also observed that there is boosted or mild-biased hematopoiesis in the bone marrow of these patients, and these mild progenitors are actually can be detected in the tumor tissue, which contributed to the migration or expansion of these tumor cells, which is a very recent work.
Okay.
Mm.
Zhang Yikwei asks, are CCR2 positive cells infiltrated into lung after stroke beneficial to fight against bacterial infection?
Yeah, that's a very good question because as we all know is that these cells contribute to our immune cells are built to combat infection, but why these cells increase the susceptibility of our lung to tissue? I think it's phase dependent uh, issue because um, we uh, we showing that during the very acute phase with no symptoms of infection, there is already a sterile inflammation caused by these infiltrated cells as well as generated neutrophils during the very acute phase, and so that suggests that the non happened um, sterile inflammation first before the subsequent bacterial infection. And from the clinical perspective, actually right now, we still do not have a very deficit definition for the stroke-associated pneumonia.
Hmm.
The 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 definition we're using now is or published actually in the 2015. It's a roundtable through conference defines that the non respiratory tract inflammation happened within 7 days are defined as stroke-associated pneumonia. And the other part is that for all the stroke-associated pneumonia, we can only identify the pathogens that cause this pneumonia in less than 1/3 patients. That indicated that bacteria may be not the first primary cause of pneumonia in this patient. It's a secondary infection. And what we identify is that it's acute stroke non-injury maybe rendered our lung more susceptible to bacterial infection. And with the support of our discovery, there's a clinical trial that's being conducted in Chongqing, published last year. Actually, they tested whether the using of prednisone combined with thrombectomy in acute ischemic stroke patients with not vessel blocker. But the primary endpoint of this trial was not met, but is a secondary endpoint in including the occurrence of stroke-associated pneumonia. They're showing that the patient actually treated with prednisone to inhibit inflammation, the occurrence of stroke-associated pneumonia are lower than the controlled ones, which uh, which suggests that the acute anti-inflammatory treatment, even a broad non-specific anti-inflammatory treatment can beneficial stroke-associated pneumonia.
I see.
Thank
Yeah. Okay.
you.
Okay. Wonderful. So next question, Lei Yao. Great talk. Is upregulation of CCR5 in bone marrow HSCs MS associated or in general?
Sorry. In bone marrow associated MS.
CCR5 expression in bone marrow stem cell.
So I think the question is whether the CCR5 upregulation in HS is specific to MS, right?
Right. I think that's a
Yeah.
question.
Well, we Uh, so obviously the answer is no, I think, because when we are searching for the mechanisms that are driving the myelopoiesis of HSCs of MS patients, we narrowed it down to CCR5, but CCR5 has previously been reported that actually it's for the in the aged HS in the HS of aged subjects its expression are also increased, which are associated with minus biased poiesis. That's is a feature of aged immune system.
I have a similar question to add on because when I listen to your talk, the reason
Mhm.
why you do CCR5 knockout is because CD4 expresses CCL5, right?
Yeah, yeah,
But
exactly.
have you so you if you knock it out CCL5, it can be just in parallel, because that's just another gain
Right,
of function. He is
right.
CCL5.
Yeah.
So have you done the CCL5 blocking or maybe CD4 express other cytokines in addition to CCL5? I mean later on you use the
We
CCL5 knockout, that's fine, but the
yeah
key is the
we
CCL5.
Yeah, we tried all the regimens, and we tested that anti-CCL5 can actually inhibit the bone marrow myelopoiesis. And also, yes, that's a very good question, and also it's a major question that raised by the reviewer
For
our
sure, for sure.
during our revision, because we cannot exclude that the blocking CSR alpha can also inhibit the migration of CD4 T cells to the brain, which might also be beneficial to MS pathology. And to
Right.
answer this question, we generated a short bone marrow chimeric mice, and we using subnasal irradiation of the white mice, and then transplant the CCR5 knockout HSCs to these mice. So the immune system actually are not fully depleted by the subnasal irradiation, but during which the bone marrow of these mice harbored partial of CCR5 knockout HSCs. Though it's not ideal, but we're using this model to demonstrate that uh, the deficit of CCR5 in bone marrow cells actually ameliorated the pathology of EAE mouse. So
Mhm.
that's partially answered this question. But I think yes, too. If you blocking CCR5, it also blocks the migration of CD4 T cell, and it definitely is beneficial to the MS pathology.
Okay. Um,
I
yeah,
oh
yeah. But we have another
Mhm.
question from the audience, GX Mon. Do you
Paul, this is Guangxun Men.
oh, Guangxi? Oh, yeah,
Uh,
yeah. Hi.
hi,
Oh, it's you.
hi.
Oh,
Please.
Kevin, very nice talk, and
thank you.
this series of work really demonstrates the complexity and the importance of interaction between nervous system and the immune system, especially bone marrow. So, um, yeah, I learned a lot, and I have some specific questions to discuss with you. Maybe I missed it. You mentioned the regulatory monocyte. So these regulatory monocyte, are they directly derived from bone marrow, or is after migration or differentiation into the target organ? Regulatory monocyte, and what do they regulate? They regulate inflammatory monocyte or regulate inflammatory neutrophils. So
Mhm.
I'd like to know more about this part, please. Thank you.
Yes, thank you for your wonderful question. I think, uh, it's a great question because right now we showing that actually the generation of this subtype of L160 no monocyte are increased in the bone marrow of SH mice, and this monocyte can readily migrate to the brain surrounding the lesion, and this monocyte uh, can can then differentiate into the alternatively activated macrophages and promote the clearance of tissue debris and the resolution of neuroinflammation. And the other part is that whether these L160 no monocytes are actually generated in situ from like L160 high monocytes, actually right now I don't know this concept the answer for this question. I think we can currently our data cannot exclude this possibility, but what we are showing is that the bone marrow generation might contribute to this process, and whether this L160 no monocytes or uh, are are derived from L160 high monocytes that migrate to the brain previously. I think it's an ongoing work actually in our lab, and we still don't have the clue and data. Thank you for the
Oh,
question. Mm,
okay. Yeah, we look forward.
mm,
Another part is for the neutrophil
mhm,
enrichment in the lung.
mm,
Um, so actually, there are also some other work showing that in the gut or in the lung, neutrophils can be sort of anti-inflammatory. So
mhm,
neutrophil accumulation is not necessarily causing inflammatory damage. So
mhm.
maybe you didn't show some details. In your case, did you show further molecular characters of those neutrophils enriched in the lung that's connected with damage?
Yeah.
Um,
Thank you for the question. I think this question is also raised by uh, our reviewers,
mm,
and we show that yes, this neutrophils quickly accumulated in the lung, and by depletion, these neutrophils, our mice are then protected from bacterial infection. So they raised the question whether these neutrophils are actually anti-inflammatory neutrophils, or even further, whether these neutrophils are bone marrow derived suppressor cells, minor derived suppressor cells. Well, from our phenotype data, the single cell RNA-seq data, we showing that these neutrophils are highly expressed L1 beta and VEGF-A such cytokines, but not the conventional uh, the conventional chemical like MMP9, and as well as the T cell suppression molecules like PDL1 are not identified in our neutrophils, and so we still believe that this neutrophils that we identify in our lung are actually are pro-inflammatory, and whether to further point whether these neutrophils are actually the MDSCs, we are still working on it to screw out to exclude this possibility.
Oh, thank you. That's
Thank
one
you.
question.
Okay, thanks, Dr. Meng. We have I think one more question from Zhang Yikai.
Hi, how are you? This is Yikui from Wenzhou Eye Hospital. I received training in NIH as a postdoc for 3 years. Nice talk, Professor Chi. Actually, my question is, there are other players, during the neural inflammation. For example, tissue macrophage. Either in the brain we have microglia, right? And in the lung, I believe they also have tissue macrophage. So I think they also play some parts, some role during the disease progression, etc. So would you please give a quick comment about the roles and also their interaction with the peripheral, bone marrow derived either macrophage or other myeloid cells? Thank you.
Okay, so